Hi, my name is Mohammad Iskandari. Today I am going to show you how to examine the shoulder. The first thing we are going to ask Mizan to take his shirt off so we can have a look at the shoulder. So as with any other joint, an inspection is important. So first we have a look at the shoulder from the front. We are really looking for any asymmetry or obvious differences between the shoulder. So in an athlete we might look around the AC joint, see if there is any differences between the two sides, see whether that joint is more prominent. We might also have a look at the deltoid muscle to see is there any obvious worsening between these two muscles, which you might see after a shoulder dislocation. We can ask Mizan to move side on. So side on we have a closer inspection at the deltoid. We can have a look at the cervical spine and have a look at the normal cervical lordosis, and then if we get him to turn face away from us from behind, we also have a good opportunity to look at muscle wasting. A good area to look is in here around the infraspinatus. And an older athlete, if we see infraspinatus wasting, we might be thinking about a rotator cuff tear, as opposed to a younger athlete, where we might be thinking more a suprascapular neuropathy. Another important place is to look is around the shoulder blade position or scapular posture. And if we ask him to bring his arms ups and down at the side, so we are abducting the shoulder, we can have a look at the scapular rhythm to see if there is any prominence of the scapula or a scapular heat chain. So inspection is really important around the shoulder joint. We get him to turn face forwards towards me again. The next thing we are going to do is palpate around the shoulder. I start anteriorly around the sternoclavicular joint, follow along the clavicle, and then palpate on top of the AC joint to see if there is any tenderness there, which we'd expect if someone had injured the AC joint. I then palpate on acromion and then anteriorly over the long head of the biceps. And it's difficult to palpate, but we are trying to palpate the greater tuberosity over the lateral aspect of the shoulder. Also useful to along the upper traps region here, sometimes trigger points which are quite tender to palpate. So having had a good feel around the shoulder, we can have a look him shoulder movement. If you turn your thumb out to the side and bring your arms up at the side, we are abducting the shoulder, and the normal range is somehow is the region of 170 to 180 degrees. So we are also asking whether it's painful movement, shoulder ups at front, any pain or problems with that. And then we can look at rotation standing up, external rotation. If we keep your elbows tucked into your side, how far out can you get your elbows? So external rotation. And then if you turn side on, so you're facing, and then how far up your back can you get your arm. So one at a time, and you can document the spinal level that they are able to internally rotate to. So if you can pair there, and then the other side, he has symmetric internal rotation, so we can assess range of motion standing. So face cam. Now we are going to test rotator cuff power for infraspinatus. Keep your elbow at the side there. Stop me pushing your hands together, looking for any pain or weakness. For supraspinatus, shoulder to be internally rotated, arm adducted, and forward flexion. Rest of the test we will do in lying position. So having got nice and comfortable, I like to assess shoulder rotation in this position. It's important to remember that the athlete may have shoulder instability, and so we don't want to be too cavalier with this. So I bring the shoulder into 90 degree abducted position. So just relax there with my hand over front of the shoulder. I gently externally rotate, so it's just assisting range of motion, so we have got no problems with that. So 90 degrees range of external rotation there, and internal rotation we can get to about 80 degrees. So if you suspect this athlete may have had an instability episode or shoulder dislocation episode, the anterior application test is also done in this position. This is why it's important to have your hand over the front of the shoulder. So we have got our hand there, applying a little bit of pressure over the anterior shoulder. The next test I like to do is a series of tests for shoulder impingement. So Hawkins and Nia tests are described with the athlete in the standing position, but I feel I have more control if I do this with athlete lying down. So Hawkins test has the athlete's shoulder abducted forward, flexed to 90 degrees, and then fully internally rotated. So what we are doing is internally rotating Mizan's shoulder and taking into slight adduction, so any pain or problems with that. So patients with rotator cuff pathology, rotator cuff impingement will have problems with that. Nia test also describe standing up as the athlete starting with their arm at their side and their arm fully internally rotated, and we bring into a flex position. I do this with the athlete lying down, shoulder fully internally rotated, and we bring it into flex position, full flexion, any pain or problems with that. So that's how I do Nia test. I also do a test for AC joint dysfunction. So I think the patient has AC joint pathology. I take the arm full cross body abduction and add some extra pressure, and if the patient has AC joint pain, the cross body adduction will easily cause pain in the region of their AC joint. The next thing I am going to do, if I think the athlete has shoulder instability, is ask them to sit to do a circus sign. So we ask the athlete to have their arm hanging nice and loosely by their side, and we are having a look around the lateral aspect of the shoulder as we imply some traction force inferiorly to see whether there is a sulcus or evidence of laxity, and there is a suggestion of sulcus. Here is the apply some traction. By this approach we can look for sulcus. That's how we can examine the shoulder.